I'd like to thank everyone here for putting on this course. It's really an honor to be faculty at this course. Any point, just interrupt me. Let's make this interactive. So we're going to talk about Spondys in young athletes. So now we know spondylolysis is a stress fracture. Now it happens in 6% of the population. Most people probably don't even know they have it, and most people it's probably not a problem. Now it's pretty specific on exam when a spondy is causing a problem. So when a spondy causes a problem, they bend backwards and it hurts right at L5. So if you have this on exam, the spondy could be causing the pain. If it's not that on exam, the spondy probably isn't causing the pain. And we found that when people came to us with spondies, on average, they were misdiagnosed for 6 months after first seeing healthcare professionals. So this is something missed all the time by people. And if we look at that video on the right, you could see that probably what happens is the nutcracker phenomenon. The L5 or the L4 inferior facets hits the pars and physically breaks it as athletes are bending backwards, whether it's a football lineman getting pushed backwards or a gymnast. But we have to make sure that the spondy is what's causing the pain. Oftentimes there's another condition called a facet fracture. Facet fractures are almost always missed on MRIs, they're missed on SPECT scans, they're really only seen on CT scans. And think of a facet fracture as being like a piece of sand in your eye. If you take it out, you instantly feel better. If you leave it in too long, it might cause arthritis and problems. And it could be taken out pretty easily. People here probably know how to do it better than me. Put it in a tube, find the broken bone, pull it out. Don't have to do much more than that. Sometimes it's so small you can take them out in a sucker. So far in my experience, if there's an isolated facet fracture that's painful when someone bends backwards, 100% of the time you pull it out like, wow, thanks doc, that feels a lot better. We did follow up on some kids, and while they all feel better instantly, down the road people do have some back pain, but this certainly allows kids to go back to sports. So let's talk about imaging in spondies. So the lateral radiograph, oftentimes will show a spondy. The MRIs may or may not show it's hot. Well, I don't think I'm going to use that anymore. And the SPECT scans may or may not show it's hot. And it's kind of a question, what do you want to get? We certainly want to get x-rays. It's really quick, really easy. I think an MRI will give you the big picture and help rule out other issues, but the gold standard of seeing if there's a spondy or not, how big is the gap, is there a facet fracture, is the CT. And maybe a good practice is get the MRI first, big picture, it could show you where it's hot, then you can get a CT just of that level, if you're going to want to try to heal it, consider surgery, or make further decisions. And in my practice, at one point, 64% of the kids that came in with a CT-proven spondy first had an MRI that was misread as having no problems. So, whenever you talk to a radiologist, they say, well, if you do an MRI like I do, you can see it here and there. But to this day, MRIs miss spondies constantly. If you have a high clinical suspicion, consider a limited CT right where it hurts when someone bends backwards. So if it hurts around L5, get a CT from L4 through the sacrum, not too much radiation, you're going to get to define the spondy. We do not need oblique x-rays anymore. All this does is give extra radiation. We do not need flexion and extension films. I know in the adult spine world, people do this all the time. I've never once seen it contribute to the care of a young athlete. Instability is not an issue in a young athlete. The only people that want you to get these are the insurance companies. That's a little bit backwards. So again, no pain, no problem. I first saw this girl when she was 8. She became an Olympic gymnast. She had like 5 doctors tell her to quit gymnastics. I said I could fix a broken bone, not a broken spirit, go for it. She had an entire career, and we can see that her spondy did not progress over time. People can play athletics with spondies, no pain, no problems. Some studies have shown that if you take people out of sports for 3 months, 50% of the time the pain goes away. Now, it doesn't always heal. Maybe it just calms down. Maybe there's a fibrous non-union. But if you don't take people out of sports, it doesn't heal quite so often. And what's important is when we're looking at images, it's very clear. If a spondy is not hot, it's not going to heal on its own. Spondies could heal with gaps of 1, 2 millimeters, maybe even 4 or 5 millimeters if you give it enough time. Not too many people want to wait 5 months, but sometimes that's what it takes. And what's also important is bracing of an L5 spondy has not been shown to be helpful. We're all told to brace because you all feel like we're doing something. Biomechanical studies actually show if you put a brace on someone, you cause more stress at L5 because you're immobilizing the vertebrae ahead of that, or on top of that. So in the old days, I do open direct repairs. It works. It's a fair amount of open surgery, but the kids could tend to go back to sports. And if we're considering a direct repair, what we want to have is a lot of bone surface area next to each other, like we see on the left. On the right, where there's very little bone surface area, direct repair might not work so well there. You might want to lean more towards a fusion in that instance. And I want to thank my partners at Cedars-Sinai. Before I went there, I've never seen an O-arm, I've never seen a robot. And a lot of these guys taught me MIS surgery, and now we do that for spondylolysis all the time. So let's go over a case. Here's a kid, 15 years old, had 18 months of back pain. Think about it. A kid, even in school, had back pain. Doctor after doctor kept saying, oh, put on a brace, go to therapy. You get a certain amount of patient blaming at this point. They must be doing something wrong if they're not getting better. I usually do not do a bone scan, but since those cracks weren't too big, wanted to be sure, yep, hot on bone scan. So we could plan this with the robot. And I'd say one of the best things about the robot is the preoperative planning. You see the red arrows up there? These screws come really close to the joint above and the joint below. I probably spend 20 minutes planning the perfect screw. And if you do it correctly, you could also have the screws come through the skin at the same point. So you could do this through one incision. Usually just about a 2-centimeter incision is all you use. And I'm a big believer in using a robot system that has both a surveillance marker and a reference frame. If you only have a reference frame and it gets hit accidentally, a centimeter off, every screw after that is going to be a centimeter off. So you want to have a system that has a surveillance marker and a reference frame, or somehow figure out how to have 2 points on the body so you know you're in the right place. Then once you make your 2-centimeter incision, look up at the screen. Now, ultimately, we don't want to be looking at the screen when we're drilling down there. Hopefully, at some point, we get augmented reality glasses, so we're looking in the same place as we're screwing. That should be the next step. And we want to have a Swiss cheese model of safety. More than once, I look at the screen, and the screw is in the perfect place. We check it with fluoro. It's not in the perfect place. So I think we want to check things with fluoro, feel the ball tip probe, get a fluoro machine in to make sure it's in the right place, and I stimulate the screws. Why not? Why not do every level of safety we can? Just takes a little bit more time. So this athlete, I did not tell him to go surfing in 2 weeks, but he felt so good he did. I never thought I'd be doing outpatient pediatric spine surgery, but now we do on a regular basis. And this really changes kids' lives. We constantly get these emails about a year later, he's playing football, lifting weights, going back to normal. And if you think about it, an orthopedic surgeon, you have like bone broke me fix, we put it in a cast and it fixes. It's a little bit harder to fix something in the spine with a brace. It doesn't just work. And maybe as we move less and less invasively, our criteria for fixing these, maybe should be a little bit lower. So this was the first one I did. I took a CT at 5 weeks. I was like, wow, what's going on? There's osteolysis. Is it infected? Is there movement? But it's an HA-coated screw. So the bone had not yet incorporated. By 9 weeks, the bone incorporates into the screw. Generally, by 10 or 12 weeks, they're pretty much completely healed. This is what it looks like at 25 weeks. And now there's some evidence that once one has a spondylolysis, there's abnormal forces at the disc, and it leads to early disc degeneration. I can oftentimes look at an X-ray or CT or MRI and see that someone's a gymnast because they have the spondy and a disc degenerated at the same level. So perhaps fixing the spondy early may save someone from disc degeneration. So here's a professional baseball player, who thought the career was over after fixing this robotically, outpatient surgery, guy's back to his career. So here's a mistake that I made. And what's interesting is you could see how far off that drill bit is and how far off the ball tip probe is. The robot screen said it was perfect, but it didn't feel perfect. The mistake I made here was when I planned with the robot, you could see there on the left where the red arrow is, the robot arm hit existing spinal instrumentation and sent us off by a few millimeters. So in this case, we had to just open it up and put it in the right place. And here's another frequent mistake that's made. When you put in an intralaminar screw, it's kind of this little knife edge. It's really easy to skive the screw off. So one way to fix that is put in a guide wire. Get the guide wire in, feel that it's in place, get a fluoro, know it's in place. What could go wrong here, right? Even a monkey could do this. Yeah, I'm not that good. I messed up here. I'm sharing this with you so that you don't make this mistake. What I should have done is as soon as the screw was past the fracture site, I should have pulled out the guide wire. I didn't. The guide wire broke. Fortunately, this is stuck in bone in the disc. The kid is 6 months out playing sports. We didn't need to do anything, just left it in place. Don't make the same mistakes I did. So what about if we have a larger gap? Like here we have a 5 millimeter gap. Probably just putting a screw across this won't work. So how do we do it? Step one is just put a screw across it. Step two is plan a phony screw with the robot. Plan a screw that's going to go right to the spondylolysis site. And then we can pass a guide wire right to the spondy site. As we have that incision, we could sneak an Acumed bone graft harvester into the iliac crest if we want to. And if we want to, you go medial to miss the cluneal nerves, as the earlier study showed. Run some tubes over this, put a microscope, and then you see the screw. It's pretty cool. You're in the right place. Take out all the fibrous tissue, throw in some bone, and it heals. And here's an example of a kid that heals 3 months later. And I generally tell kids, you will be healed at 3 months. You can go back to sports at 3 months. I don't think I've had anyone that has it yet. And this is what it looks like a year out. You have 2 little incisions, one for the screw and one for the direct repair. One for the bone grafting. And this is a kid who's a doctor's kid from the East Coast. Look how much bone is there 12 weeks post-op. She went back to volleyball, 10 weeks after surgery, 2 centimeter incision plus another 2 centimeter incision. So spondylolisthesis is way different in the young and the old. In the young, it's virtually always a fracture. Great majority of the time, it's at L5, and you treat it as a fracture. In the old, it tends to be at L4, L5. It's degenerative, it slips over time. There's not always a fracture, and the ligaments are stabilizing L5. So when we think of spondylolisthesis, it's a completely different animal in the young and the old. And, I was fixing the spondylolisthesis from the back with the T-lift. And I noticed I had a lot of failures, like 4 years out. These kids are going back to sports, and as I was speaking at different medical centers around the country, a lot of people are having these failures. We put together 5 busy pediatric spine centers. We had a 40% reoperation rate of fixing spondylolisthesis from the back. Even if you used a T-lift, it didn't help at all. A lot of nerve root irritation. And for some reason, while a posterior fusion instrumentation and T-lift may work in adults, it doesn't in teenage athletes. I think they're just too active. So in teenage athletes, if there's not too big of a slip, we now do a ALIF and posterior instrumentation. I have had one case that's now a month out, I think, of retrograde ejaculation. If anyone could teach me about that, I'm open to it. It made me a little bit shy to do an ALIF in a young athlete. So let's talk about high-grade spondylolisthesis. And I think I'm going to make some of my adult colleagues cringe here with what we do. So this is a 15-year-old level 10 gymnast, dreams of a college scholarship. Her back pain has gotten so bad she can't even sit up in school anymore. If it hurts when you play sports, it's up to you if you want to get it fixed or not. But once it hurts when you're in school, you probably need to get it fixed. So this is how I fix it. I like just leaving it in place. In the SRS database, the only surgery where the complication rate is increasing over time is high-grade Spondys. And that's because whoever's on stage says, oh, if you reduce L5 my way, you won't get a nerve root injury. But the guy who's not on stage does get nerve root injuries. And we know statistically, there's a lot of L5 nerve root injuries when you reduce L5, even if you're doing it partially. So if you're working with a robot, it is unbelievably easy to put in the L5 pedicle screw. You know, when you're doing that open, it looks like it's 10 miles down there, you can't see anything. You know, right now, I'd let the PGY2 resident put in the L5 pedicle screw through a robot. It makes your life much, much easier. And also, you know, that home run S1 transdiscal L5 screw, you know, it just becomes much easier as well. Technical tip is you want to put in the screws at L5 and 4 first, and the pelvis, and put a rod across it, because otherwise, if you're drilling across S1, L5, you may separate it a little bit, and that causes basically a reference frame shift, and the screws after that could be off. So here's what this kid looks like post-operatively. Effectively, this S1L5 screw is anterior support. I've done this surgery now for 28 years. I've never seen one fail. I've had a lot of people go on and do D1 athletics. You know, here's a typical kid. This is our level 10 gymnast. You know, 3 months out, pretty good motion. And even though you look at the x-rays and cringe, you know, it doesn't look perfect, the patient's bodies look perfect. I think as long as you get the L4 S1 to about 45 degrees of lordosis, I should have done better here. You know, I think that we could have good long-term success. And here's the patient, you know, did a full career as a level 1 gymnast at NCAA after that surgery without any problems. So that's it. Open to questions.
That was simply fabulous. And again, just starting with the workup and the assessment towards the surgical fixation strategies, that's a really big deal. So let's start with flexion extension films. Did I hear you right? We don't have to do those anymore?
You know, not in the young athlete. Now, I think it plays a decision-making role in adult Spondys, but it doesn't in young athletes. Like if, you know, the indication to fix a Spondy in a young athlete is pain, and I think I'm going to fix it the same way, whether there's a little bit of motion demonstrated or not. And I think we effectively get a lot of information from the MRI or the CT. When the patient lays down, you see how much it reduces without gravity.
Rapid fire question number 2, stress fractures. So we know, and you know way better than I do, that stress fractures, let's say in the extremities, are actually a very pathologic process. It's a devascularization and a sclerosing of cortical bone. So it's actually a dead zone. There's nothing living in there. So how do you get around resecting that and supplanting that? When I do pars repairs, I actually cut out all that dead stuff, put a corticocancellous graft in there, and then put a very archaic dinosaur fixation on there. But I'm very comfortable with that. But how can you get away with just a far less invasive surgery and then get the bone to transgress?
Yeah, I share your concern, and I was very nervous doing these for the first few. And I think if you only have a 1 millimeter crack, it seems that putting in an HA-coated screw and having such rigid fixation on both sides is enough. You know, all I could say is it works. But I, too, believe that if you have a gap and if the MRI is not hot or the bone scan's not hot, it's dead bone, you probably want to take away more bone than you leave. In those cases, I'll use iliac crest bone graft and bone morphogenic protein. And using both of those things, it seems to work.
So the heat assessment, meaning the activity, the osteoblastic activity assessment, still plays a role in your surgical grafting.
Absolutely. And, you know, these techniques may not work in 60-year-olds. You know, if you're not a good technical surgeon, do peds. You have better protoplasm. The kids heal better.
Now, final question from me. And this is just spectacular. It's such a rich and wealth of information that you gave us in a short time. Female high-grade Spondys and internal fixation. Do we have to worry about S1 screw prominence? Do we have to worry about, in these dysplastic pelvi, to actually put screws that go into the pelvis, meaning sacropelvic fixation, like what you showed in that one case? Is that a problem for the natural birthing act?
Maybe. I've had enough people express concern that if we put in great big pelvic screws and someone's pregnant, will the pelvis be able to open up or not? So what I've started to move to is using 2 S1 screws and 2 long sacral alar screws that are HA coated. I'll give you more feedback after I have a few years of follow-up with that. Yes, sir.
Quick question. This is from Linda regarding somebody in the chat box. Pars repair is an inpatient code only. Do you do this in outpatient and an ASC?
I do this outpatient all the time, but I guess I do it in Cedars Medical Center. Maybe that's not an ASC. Maybe that's the way around it.
Sounds good.
No. Anything else? Thank you. Oh, yes, sir. Please.
I guess the microphone is not functioning correctly. I just had a question about.
One second, let's have the microphone. There's nobody can hear you. Just tell us. Here, take this. Sorry, what's your glass? So tell us who you are, where you're from.
Awesome. PGY4, UC Irvine. Question about the grade 5 spondylolistheses, the spondyloptosis. Do you also not reduce those at all, or what is your
I do
treatment
not
on that?
reduce those. Now, if the patient has significant nerve root pain, do a huge decompression, big enough to drive a truck through. But I found as long as you put 2 big pedicle screws across the disc, it seems to hold and it fuses over time. I've been lucky enough to get some CTs, years out, and they just start to fuse. Get them in place. Yeah, thanks.